All right. Well, good morning, and thank you for your kind invitation. I think this is the second time I am ever around patients' associations. I don't know. It's my first time, so I'll try to make myself understood. And thank you to the organizers, and sorry for having been difficult with my agenda. So I would like to start by talking about the guidelines that have been updated. We will be looking at previous guidelines. We'll go into how important to have one such guide is to go deep into a significant parameter in diagnosis and follow-up, i.e. relative exchangeable copper, REC, which is a new parameter who will help early diagnosis very much, and it will allow us to be more accurate. But we also need to undertake in a multidisciplinary approach. We can't all freelance, or else patients will be at a loss here. So be very brief about this, because you know this better. It's an autosomal recessive copper metabolism disorder caused by mutations in the ATP7B gene, which is long on chromosome 13, which encodes P-type ATPase, which is essential for copper transport. And it has an effect on the biliary excretion and functioning plasmin which bonds copper. The plasmin is abnormal, hence we have a decreased plasmin, and when this happens, the copper accumulates in tissues, and then you have more toxic free copper in circulation. It is a very rare. We're talking about 1 in 30,000 / 1 in 50,000. Very heterogeneous, with 2,700 mutations, 800 with a confirmed pathogenic role, confirmed in Spain. In Spain, there's a gene map, and we've seen that the most frequent mutation has a low penetration in Spain, which has perhaps led to under-diagnosing, because when you look at the most frequent variants, this is not frequent in Spain. You know that there are numerous signs and symptoms, and they can happen together, liver involvement, and it could be in symptomatic patients with transaminase. It can even there can even be cirrhosis. Neurological signs and symptoms would be tremor, ataxia syndrome, dystonia syndrome, bradykinesia syndrome, which is similar to Parkinson's syndrome. It's numerous neuropsychiatric involvement, and ophthalmic, like the Kaiser-Fleischer rings. This can happen at any age. It's infrequent before the age of 3. It's usually between the ages of 5 and 35. I am no expert in anything. I'm just a good clinical guide user. Clinical guides are of the essence for us, because they include the scientific evidence. Everything that is new is included, and it also homogenizes or streamlines patient management, so that we all work similarly across the board everywhere. And it's taken a lot to have these guidelines. They were first in the States, and it took a little bit longer for there to be one here, but it's happened, and it's been super useful. And we have this REC was not incorporated back in 2022, and it was used to be broken down depending on the involvement, if the liver is involved, if there's neurologic involvement. So this is the involvement, and then we see that there's a massive gene sequencing or these magnification of so here we see the treatments. It started with chelating agents. And something that's interesting for you, we're seeing a daily single dose approach. It is important to be able to take this once a day. In terms of follow-up, we include this parameter to really monitorize well, to follow up well. It's complicated. We see certain different criteria for acute liver failure so that we can find an accurate diagnosis and avoid transplantation. And it clearly establishes when transplantation is the best option, and in terms of neurological involvement, it establishes all the tests that need to be run, clinical evaluation when as indicated, there's scales. So I'm going to speed up, and at the end of the day, definitions have been fine-tuned, especially in acute liver failure, in pediatric cases during transition. And it's important the inclusion of relative exchange of copper. It's an additional diagnostic parameter that helps in diagnosing the condition. And we also personalized algorithms is important. Here you see the general algorithm. You see the scores and how they've included this copper concentration, which allows us to know whom to start the treatment with without awaiting further tests, which will speed up the process and address signs and symptoms fast. In terms of REC, this is the ratio of copper not bonded to proteins compared to the overall copper. This is the bioavailable copper, which is toxic, and the diagnostic value, this is the cutoff point. It's 15%, which is very different to the regular value, the normal value, and it's less affected by inflammation. Hence, its accuracy for diagnosis purposes is way better. So, with great sensitivity and specificity, I mean, the diagnosis is very accurate. The family screening is important. It's important to know who is a carrier, who is going to develop the disease, who will not develop the disease. So it's really important. And here you see the traditional markers, sort of plasmide and copper, and the specificity, the sensitivity, which is greater. And then this would be the Leipzig score, which is the diagnostic pillar that was already back in the 2012 guidelines, which includes chemical, biochemical parameters, imaging, and you see the accuracy in diagnosis is 95%, and if the score is 4, you have to start as soon as possible, and this has been worked on especially in the pediatric patients. And this is the cerplasmin, serum cerplasmin, and copper in urine. 24 hours are important, but additional diagnostic tools are necessary. In terms of genetic analysis, this must be done across the board for confirmation purposes, and will help with our screening, not with the most frequent variants here, but we need to use the complete gene sequencing. Let me continue, and this is a liver biopsy, a slide on liver biopsy, which is only for cases where a diagnosis cannot be established using previous non-invasive methods. So if a biopsy needs to be conducted because there is a typical presentation, doubtful cases, or coexistence with other liver diseases, because sometimes there is a coexistence of conditions and the biopsy is necessary. This is used when you have a Lipset score, copper quantification, and here you see the positive rhodonine tinction, and this protein here is going to take copper to protect when there's no stereoplasmin. So with Wilson's disease, the distribution is diffuse, very characteristic, and it is going to be included in the guidelines. And when we perform biopsies, we need to look at this. This is liver fat. On Wilson disease, it overlaps fatty liver and hinders diagnosis. Other tests need to be run always, as you know. This characteristic ring to the copper deposits. It's the Kayser-Fleischer ring. It is present in 95% of patients with neurological involvement, and it improves or is resolved with treatment, but it is a parameter that allows for follow-up. And this is a new brain MRI to all patients. Of course, if there's neurologic involvement, if in the absence of the latter, the brain MRI is also mandatory, and after the years of 10, it has to be done. And this is the giant panda face pattern, which is very characteristic, and you can see this in the thalamus and the midbrain, and it has prognostic value. If you look at this, it's important also to know if the treatment is proving successful, and then we also need to conduct a functional examination using tests so that we all use the same data as we use the scale. I'm not going to go into the details, but in a nutshell, this has to be performed and repeated yearly to appropriately characterize all the neurologic clinic signs and symptoms because of lack of adherence to the treatment or because that's the onset of the condition. As I mentioned earlier, we now have algorithms for each presentation, including for family screening. So this allows us to know the route that needs to be taken. But across the board, you see that REC is included because of its significant value for diagnosis in terms of clinic diagnostic challenges. Sometimes there's an overlap, there's a coexistence of condition, and it's tricky. But apart from fatty liver, we have autoimmune hepatitis, which are increasingly prevalent, and it might be challenging to discriminate both conditions and need to use all of these markers. As I mentioned earlier, REC is good not only to diagnose but also to screen. And here you see how to discriminate a patient with a disease. Look at these values from a carrier that is below 15%. So, and here it's really easy. 6%, no disease. So this will allow us to know who is affected when you look at the family, the parents and offspring. This is the treatment, the chelating agents you're aware of. These are the drugs that are usually used when there's liver in condition with penicillamine and trientine. Sorry, I haven't slept much, so I can hardly say the words I want to say. You need a close follow-up at the beginning of the treatment because this could worsen the neurologic symptoms, and you need to be cautious of the meals taken. There's a novelty to explore a single daily dose, and the perspectives are quite promising. And it would be wonderful, if you could only use this once a day, and salt is here. I think salt is an alternative, and then there's controversy initiation of treatment in carrots who are symptomatic. Right now, close monitoring is the choice, and then initial therapy in mild forms without significant liver involvement, whether you use chelating agents or zinc. This is a controversy, and it all depends on drug availability.
As for the monitoring, the recommendations, basically this is a personalized medicine. We need to adapt the medication and basically individualized adjustment based on clinical presentations with the REC values depending on age and comorbidities. This is a very important parameter. So the copper and ceruloplasmins, it's very difficult to measure all that. It's not real. Sometimes we don't even know what the chelating copper situation is. It will help us, not as a cutoff point, but our colleagues that are working on this, and I think it's the same in other countries, if we check the interpersonal changes, we would get more sort of reliable monitoring and measurement. Well, how often? It has to be very frequently, right at the beginning, until we are initially maybe 2 to 4 months until we get stable, and then every 3 to 6 months, repeating all these neurological tests every year. Right, this is the worst scenario actually, but for the within the liver context has been very important. The definition of acute liver failure in Wilson, and basically having a fast diagnosis. This was not defined previously, knowing what is an alteration of coagulation over 2. The INR, the value more than 1.5, we have encephalopathy, regardless of any chronic liver disease, because in Spain an ALF is considered if we have an underlying healthy liver. So we activate the emergency national code, which is the 0 code. So if we had a chronic disease on the liver, we wouldn't be able to activate 0 code. But if we have an ALF with a Wilson condition, obviously, regardless of the year or of the condition, these become acute liver failure. We have the intervention, basically, with chelant therapies, with plasmapheresis, and the evaluation. If we have an encephalopathy or without encephalopathy, basically we have here different sort of action lines, and this would allow us to save the person, basically treat them without a transplant, and if we need a transplant, basically be there on time, which is what we are aiming to. In terms of liver transplantation, we have the traditional indications, acute liver failure with encephalopathy or modified King's College criteria, but we've seen that also there's a new issue here. There's a new indication, severe progressive neurological deterioration despite a optimized chelation agency, which is 3 months, with adequate adherence. The evidence is limited, that's why it needs to be individualized, but the results are just here. The neurological improvement happens in 70 to 85% of selected cases, with the stabilization of neurological manifestation within 1 to 1.5 years. What are these cases? Well, patients with a favorable neuropsychological assessment and without symptoms lasting for a long time. And we'll have to discuss whether the transplant is going to be beneficial, if that's going to improve the situation of the patient, and also the transition I'm going to mention. And this is a sort of a battlefield here, and this is a bone of contention. Actually, I know that we have lots of problems because you might have morbidity, adherences, medical complications. Sometimes people rebel against their condition. People stop taking the medication, and so many things. You might have memory deficits, learning difficulties, poor school performance, mental health problems, as you mentioned, in self-harm and suicidal ideation also has been reported. So we have to work very hard together. We know we need these transition clinics in Wilson and in other conditions, but it's very important here. Basically, multidisciplinary transition clinics with integrated teams, pathologists, specialized nursery as well, being the bridge, and also looking at all these success factors, higher education, family support, and positive attitudes toward treatment. So the recommendations is to start early, 12 to 14 years old, and then reach to adulthood when a person is able to self-care. So in between those that time, that age, will finalize the transition and will move to adulthood. So implement specific programs that promote autonomy, independent minimum teams, multidisciplinary teams, and also joint or alternating clinical consultations with pediatricians, but always coordinated. And finally, the unmet needs and the priorities for researchers, basically to validate the scores that we have right now. The Leipzig score has been only validated in children. Having validated biomarkers, and they should be rapid molecular tests are needed, especially if life is at risk. Basically, an evaluation of the effectiveness of chelating agents in neurological manifestations. Population screening, I think that we'll be discussing that today, having a test that allow us to basically examine the children as well and the transition programs. In terms of the treatment, here on the right-hand side, we need more potent chelating agents for severe or refractory clinical conditions, basically with improved side effect profiles and also the adherence to avoid failures, the gene therapy, and I think a colleague will be dealing with that this afternoon, with low therapeutic agents and knowing exactly where to go in terms of evaluation of the liver transplant. These are the conclusions. It's very important to redefine the standard of care, how we are going to manage our patients in a comprehensive way, looking at the neurological manifestations in a standardized manner, with a specific criteria for this pediatric population and recommendations for transition. We have an enhanced precision diagnosis with incorporation of the REC that will help us to diagnose, monitor, and also to screen within families. The Leipzig score remains valid also. And in terms of the therapeutic management, we have a structured protocol for acute liver failure and the transplant also. So it needs to be a personalized approach based on your clinical presentations, advanced biomarkers, and evidence-based medicine. And that is all. Thank you very much. Any questions? Any remarks?